जयश्री we are live.
Okay.
Recording पण चालू करा हा.
Good afternoon, everybody. On behalf of Palghar Academy of Pediatrics, we welcome you all. Today in this Wednesday Wisdoms webinar, that is WWW, we want you to know about the programs which we are conducting in IAP Palghar branch in this month, where we celebrate the awareness of TB is created in society. I asked Dr. Anjali Gokarna, our August president of IAP Palghar, to talk about the programs which we are conducting on behalf of Palghar Academy.
Good afternoon, everyone, and thank you for joining in. This 3 p.m. is actually siesta time for most doctors, but I'm so happy to see that there are at least 20 of us who are here to be present for this webinar. IAP Palghar has been active for the last 2 to 3 years, conducting webinars every month, sometimes even more. We also have many live or in-person meets and community projects we do. This month was World TB Day, and in fact, it was last month, and we conducted some events this month. Dr. Jayashree Deshpande helped us to register as Nikshay Mitra. And Nikshay Mitra means any NGO that is willing to work with Nikshay and with the TB authorities to work for patients suffering from tuberculosis. We know that the government gives each patient who is suffering from tuberculosis rupees 500 per month. But also we know that in the prices that are undergoing so much inflation these days, 500 rupees really gets distributed amongst all the children and the family and not enough for the index person suffering from tuberculosis. So the Pradhan Mantri, our Honorable Prime Minister Narendra Modi ji has suggested that if we can supply something like a nutrition basket to each of these individuals, it will be really, help them in their recovery, and that is what we have taken up. We thought we'll do a small project, and we have done that with 30 children, and 32 in fact, and 32 children from Vasai, Virar, Nala Sopara Urban Primary Health Center were called for an examination and a meet to reassure them that they are very much loved and part of our society, and they were examined for any side effects or any other issues they may have, and they were given a nutritional basket and a small tidbit teddy bear and a small soap just as a gift of love from all of us. And the response was good. The parents liked. The pediatricians, yesterday Dr. Jayashree spoke with all the parents about the importance of proteins and including all that in the diet, and we gave them a small nutrition basket. I'm happy to say that IB Palghar has also been able to, work with the Rotary of Vasai, and they have promised that from next month they will be supplying this nutrition basket to 80 children of Vasai. And now we are planning that perhaps we can also include Nala Sopara and Virar UPHCs in the larger. They are willing to even escalate the project. So I hope that we are able to reach many more children. We have about 300 children in Vasai, Virar, Nala Sopara, and about 4,000 total patients. And it is our Prime Minister's dream that by 2025 we should be able to eliminate TB, and that's also something we are working towards. And this is our small bit that we can do. So we can do whatever we can and hope it helps. So this was our Nikshay Mitra program that we have undertaken. We have a very important other life-saving event also coming up on the 5th of May. That is a Friday. And we are planning a BLS, a basic life support course. And anesthetists of Virar, Vasai, Nala Sopara are going to join hands with mannequins and going to train. And we want people to register. There's a small fee of 300 rupees. So anyone who wishes, and BLS, believe me, is nothing like the ALS that we do. Advanced life support is something different with intubation. And but if you are present, say in a gym when you are exercising and somebody collapses, or like on the airport and somebody collapses, we don't know how to save an adult. We don't know how to use the AED. This will be taught in that program. So please do attend on the 5th. And for further inquiries, the same place where you have, informed, you can inform us, and we'll be happy to tell you all about it. That's all I have to say. And over to you again, Jaish.
Thank you, Anjali. We welcome you all on this August afternoon, and it's a great pleasure for me to introduce our August speaker, Dr. Reshma Jain, Madam. Welcome, Madam. Dr. Madam is practicing at Anand Mother and Child Hospital, Malad, and also at Kandivali. And she's also an international board certified lactational specialist. Since we are like having an awareness month for TB this month, we would again like to know something more about BCOitis, not BCitis. Over to you, Dr. Jain, Madam.
Thank you, ma'am. Is my presentation visible?
Yes, madam.
So, good afternoon, everybody. I would like to thank Anjali ma'am and Jaishri ma'am for giving me this opportunity to present in today's on today's platform. So, the topic given to me is a case that we will be discussing today. It's about BCGiosis, but it is not bound to TB. It's beyond tuberculosis. Okay, as madam gave my introduction already. Okay, so we start with the case. This is a 2-month-old girl born out of 3rd-degree consanguineous marriage, presented with swelling over the left axilla since 10 to 15 days, fever intermittent for 5 days, and generalized rash over the body for the last 4 days. Swelling appeared in the left axillary area, which was pea-sized to begin, gradually increasing in the size to the current size. Fever was mild to moderate grade, and there was macular erythematous rash over the body. There were no other history of cough, cold, or loose motions, vomiting, swelling anywhere else in the body, or fever in the family members or siblings. On examination, significant findings were baby was vitally stable. There was maculopapular rash all over the body. BCG scar was present. However, there was no swelling over the scar. Swelling was there in the left axillary area where 2 distinct nodes were felt. Systemic examination wise, the child was normal. So here presenting the pictures of the rashes. So this was a diffuse rash all over the body. This picture is just after the biopsy. So we can see the sticking here of the axillary node biopsy done. This is the BCG scar here. I just point it out. Okay. So the scar was not inflamed or showing any inflammation per se, but there was axillary lymphadenopathy. Birth history wise, it was a full-term born out of cesarean section. Indication was previous LSCS. Baby had cried immediately after birth and birth weight was 2.5 kg. This was a 3rd child. The first baby is a 5-year-old girl, alive and well. The second baby was had expired at 4 months of age. The details I'll share later. And this was the 3rd baby. The child was exclusively breastfed, had received birth vaccination. Development-wise, she had social smile, eye contact, and was able to focus and follow with eyes. And socioeconomic-wise, they belong to upper middle class family. So on the basis of history, we made an impression that it is probably a BCGiosis to rule out immunodeficiency. It is BCGitis is only at the site of the BCG vaccine. BCGiosis is more than one site. So probably the rash or could also be a part of BCGiosis is what was thought for. Course in the hospital, symptomatic management was given. Biopsy of the axillary lymph nodes was done. Dermatology reference was taken for the rash, but they suspected it could be allergic rash, not so much with conclusion. Sibling death was because of query HLH query osteopetrosis. So some kind of immunodeficiency. So these are the reports of the biopsy. So we can see Mycobacterium tuberculosis was detected and rifampicin resistance was not detected. And it was a suppurative lymphadenitis of the biopsy of the lymph nodes. The baby was then transferred to Vadia Hospital for further course or further management because we suspected immunodeficiency in this child. So there, GL gastric lavage for gene expert was performed and it showed AFB was positive. So diagnosis of BCGosis was confirmed where AFB was isolated from 2 different sites. The plan was also to detect skin biopsy and to prove AFB in the skin rashes, but the parents were not willing for the same, so that was not done. The child was started on AKT. Since BCG vaccine or BCG bacillus is inherently resistant to pyrazinamide, that is why HRE and ofloxacin was started. The old record of elder sibling who expired was traced. It showed homozygous mutation for osteopetrosis and heterozygous mutation for HLH, hemophagocytic lymphohistiocytosis. So the baby who expired at 4 months of age was having osteopetrosis, which is an immunodeficiency. So on similar lines, HLH workup for this baby was also done, which was negative. X-ray of long bones was not suggestive of osteopetrosis. Because of BCGosis, lymphocyte subset analysis and for CGD and severe combined immunodeficiency. So NBT DHR was done. So and lymphocyte subset analysis was done. So this ruled out chronic granulomatous disease and severe combined immunodeficiency. So these were ruled out. So this is the response that was seen after 1 week of AKT. So the rashes resolved significantly. So probably the rashes were also a part of BCGosis. So finally, after all this, the whole genome sequencing of this child was sent for diagnosis, and it showed homozygous mutation in interferon gamma receptor 1 gene, which is responsible for Mendelian susceptibility to mycobacterial diseases, and hence the child suffered from BCGosis. Okay, so this was a homozygous defect and in the interferon gamma 1 receptor, which was made as a diagnosis of this child. Currently, the child is fine, doing well on AKT. The further plan for this child is the child can be offered transplant. There is an elder sibling who is alive and well. So the further plan is to match the elder sibling with this child. Before that, the elder sibling has to be screened for any kind of subtle mutations. Basics of immunology. Here I would like to just highlight this diagram is very simplified diagram to understand that with normal immune response, if the normal immune response increases to external antigens, we have allergy. If normal immune response increases to internal antigens, we have autoimmunity. If normal immune response decreases to external antigens, we have immunodeficiency, and it decreases to internal antigens, then can lead to neoplasia. So this is a simple diagram which I found in this article, but I found it very useful to understand how it is going to manifest. So a lot of immunodeficiency also manifests as autoimmunity. So it's kind of a spectrum in one immune system. So this is a very simplified types of immunodeficiency, just to highlight as a pediatrician point of view what we must be aware that of different types. There are many more types in it, but I have just classified it into 4 and made it a little simpler for us to understand. So primary antibody deficiencies, combined immunodeficiencies, phagocytic defects, and complement defects. So as the word says, primary antibody defects, so antibodies will decrease because maternal antibodies are circulating in the baby's body. So this patients may manifest at 4 to 6 months of age till they have a cover by the maternal antibody. Combined immunodeficiency, that is lymphocytes are decreased, T cells are decreased, and impaired B cell function. They can present early after birth. Phagocytic defects, decrease in the number or function or both. They can present anytime. And complement defects, decrease in the complement factors, even they can present anytime. This is the list that they are susceptible to: bacterial infections in all, mycobacterial in combined immunodeficiency, phagocytic. So lot of where different infections they are susceptible to. Prototype of these kind are, this is X-linked gamma-globinemia, combined severe combined variable immunodeficiency, SCID, Wiskott-Aldrich syndrome. Phagocytic defects is chronic granulomatous disease, neutropenia, and leukocyte adhesion defect. And complement defects is early or terminal complement defect pathway. Just as a pediatrician point of view, when we see patients in the OPD, where do we have this warning sign that we should know that we should suspect a primary immunodeficiency in any child? This is Jeffrey model. So 4 or more new ear infections within a year, 2 or more serious sinus infections within a year, 2 or more months on antibiotics with little effect, 2 or more pneumonias within a year, failure of an infant to gain weight or grow normally, recurrent deep skin or organ abscesses, persistent thrush in the mouth or fungal infection on skin, need for IV antibiotics to clear infections, 2 or more deep-seated infections, including septicemia, and a family history of PID. Okay, so these are warning signs where we should be alarmed whether we should closely follow up the child for any kind of immunodeficiency. 2 important lessons that we learned from this case was, always you should look for absolute lymphocyte count whenever we do a CBC in a neonate. It should be more than 3,000 in neonates. Anything less than 3,000 should be alarming and give us an idea whether we should watch this child for any kind of immunodeficiency, because neonate is a lymphoid organ. So the lymphocytes should be significant in number. So if the absolute lymphocyte count is less than 3,000, then we should be worried. Live vaccines. Now, we should avoid giving live vaccines in cases where there is a sibling death with suspected or proven immunodeficiency. Because until and unless it is proved whether that child had immunodeficiency and expired of immunodeficiency, and this child without any investigations, we should at least avoid the live vaccines. So I thank the parents of the patient and my Anand Mother and Child Hospital team and Dr. Vijaya Gauri Madam from Vadia to help me to know about the follow-up of this case and help me in knowing a lot of things about immunodeficiency also. So thank you so much.
Thank you, Dr. Reshma. It's really interesting to know such a rare disease. And we will be aware about giving live vaccines to the children who has a family history suggestive of immunodeficiency. Anybody wants to ask any question? Dr. Murthy, you want to comment something?
You have to unmute yourself.
Yeah, it's quite an eye-opener. I just saw a child of suspected BCG lymphadenitis the other day, and they wanted to come back later for some simple blood tests. I mean, just it's an eye-opener and makes us more aware of the existence of such things, and it's a reminder that I mean, I've not seen BCG adenitis for so long, so it was just a refresher and very nice, well-presented report. Thank you.
Yeah, but Dr. Murthy, for that BCG lymphadenitis, what did you do?
Nothing. They said they will not investigate now. They said they were visiting from the mother's Mecca's house. They came here. They said we are going back.
Yeah, because I think the guidelines say that you have to leave an adenitis alone unless it forms an abscess.
Yeah. They didn't want to wait for follow-up also. They said we'll go back to the doctor who gave us the BCG, and I asked them to follow up.
I think Reshma suspected something because this child had fever and your patient must not have had fever.
Yeah,
and
it was just an incidental finding.
And obviously that child had other symptoms. Reshma, you want to say something about that? Why you suspected an immunodeficiency? Why did you go for a skin biopsy? or a lymph node excision biopsy?
Ma'am, in this case, there was a clear-cut family history of a sibling death. And ma'am, there was another case that is why we suspected that it could be an immunodeficiency. There was another patient who had presented who at 9 months of age with BCG or BCG adenitis. In that also, we thought that we should go ahead with finding out whether there is an immunodeficiency, because there was no other, that was the first child. No other reason that why should the child get BCGiosis. So in that child also immunodeficiency was diagnosed. He was also diagnosed with MSMD. So probably I think with altered response, which was not generally expected in after live vaccinations, we should suspect.
Yeah. Another thing I just want to mention that BCGiosis can be presented as late as like 6 years or 8 years or any time in your life. So what is the last like where we should suspect whether this is a BCGiosis? Till what age we can say? It's like 18 years for us, but for adults also they present?
I think we have Dr. Vijaya online. So maybe she can come.
Dr. Vijaya?
Can we speak? Can I speak, ma'am?
Yeah.
I'm Dr. Vijaya from Palghar Hospital.
Please,
Yes,
we are honored to have you.
Welcome, Madam Vijaya. We want your comments on this.
Yeah, so
We can't.
yeah, ma'am. So yeah, so basically,
Vijaya, can you put your video off?
when the child, as Reshma actually said that the first child which she had
Madam, we are not able to hear you properly. Can you put off your video and talk on otherwise without video?
Yeah, yes.
Yeah.
She got enlightened about MSMD or Mendelian susceptibility. Thank you, ma'am. Thank you so much. Thank you, ma'am.
Madam, we have not understood. Madam Reshma, can you?
Lesion. So that child initially had a lymph node abscess. I switched off my video.
Yeah,
So
yeah.
It's hello. Can you hear me now?
Yeah,
Come
it's
out.
better.
Yeah. So basically, the other child who was referred, whom Reshma has not presented, was also referred with a lymph node abscess, which was actually left axillary lymph node abscess. And that child went on to develop a skin lesion, which we biopsied, and FD was positive. So we had more than 2 sites, which was the lymph node as well as the skin. And then we went on to do the investigation further, and we sent an exome sequencing. So, so basically, the dictum is BCGiosis should never happen. BCG is a live vaccine. When given, you should get an adequate response. And more than 6 months, if there is a development, if it is inflammation at the site of BCG, even IAP says if the site of inflammation remains for almost 6 months, and beyond that, if you develops into a swelling, localized swelling, and then then it goes on to develop a skin lesion, which we always consider it to be a eczema or something like that. But this is actually a disseminated BCG, which is manifesting as a skin lesion. We should go on to look for skin lesions in the liver. We should look for lesions in the spleen. Sometimes the child comes with a seizure, so we should look for lesions in the brain also. And that is a disseminated BCGiosis. Disseminated BCGiosis is responsible for, seen in Mendelian susceptibility to mycobacterial disease. It's an MSMD, we call it. And it is, there are 23 genes resulting in 31 different phenotypes. And it is IL-12 receptor interferon gamma loop defect. So IL-12 is a cytokine. Interferon gamma is again a cytokine. Both these cytokines, along with our STAT proteins, are responsible for prevention or taking care of mycobacterial infection. Whenever there is in these 23 genes, if there is a defect, you can manifest with Mendelian susceptibility to mycobacterial disease. So what we have realized here is what we think is not very common is actually very common. all these MDR, XDR tuberculosis who are not actually responding, or tubercular osteomyelitis, or recurrent episodes of tuberculosis have an underlying mutation which is unable to eradicate that mycobacteria. And that is why we should always look for an underlying genetic mutation. So my sincere request is, whenever a child comes with a history of a BCGiosis or a BCGitis with a lymph node abscess or something which is not actually healing, it should always be investigated further. And we at Vadia Immunology are able to send the samples to NIIH, as well as we get a whole exome sequencing done, and we treat the child appropriately. Reshma actually presented is interferon gamma loop defect. It is interferon gamma receptor 1. This child can undergo transplantation and can improve.
Is this related to the osteopetrosis child? Is it the same gene?
So, okay, ma'am. So, yes, ma'am. The interferon gamma defect child is also related to osteopetrosis child. Now, that osteopetrosis child, that entire family looks like museum of mutation, because the second child who died had osteopetrosis and a heterozygous mutation for HLH. She actually presented with pancytopenia and was treated as HLH in Gujarat. And that the baby succumbed. When at the deathbed, when her EDTA sample was sent, her mutation was osteopetrosis, but the child had died by then. Now, when the third child came to us and we had this mutation in hand, we thought probably we are dealing with osteopetrosis, because that was a homozygous mutation in the second child. But this child did not show any X-ray. We did a X-ray screening for this child, but did not show any features of osteopetrosis. Then we looked out for HLH, because the second child also had HLH and it was a heterozygous mutation. We thought this child might be homozygote for this. So we looked for HLH, because HLH can be triggered by anything, any infection, including Mycobacterial bovis can trigger an HLH. And Mycobacterium bovis dissemination can occur in CGD, as Reshma said, and many others in the group had said. Then also CGD, SCID, the combined immune deficiency. In all this, you can have disseminated BCGiosis, which is a live vaccine. BCG is a live vaccine. So we actually looked for HLH parameters. Everything was normal in this child. And then we thought that probably we should look for, probably we are dealing with SCID. Her absolute lymphocyte count was also normal, and she had a very high eosinophil count. So we thought that from the very beginning, her first CBC done at day 5 of life also had a very high absolute eosinophil count. So we thought that high lymphocyte count in this baby is because of maternal lymphocytes. High eosinophil counts is indicative of a maternal graft versus host disease, and probably this child has a SCID, severe combined immune deficiency. So we did an LSSA. LSSA was bang normal. We analyzed the entire flow cytometry. It was bang normal. That is when we thought, okay, now we don't, and NBT-DHR, which was done for chronic granulomatous disease, was also normal. That is when we thought that probably we are now dealing with Mendelian susceptibility to mycobacterial disease, and we had the mutation there. But this child is heterozygous for osteopetrosis gene, which is an autosomal recessive gene. So if she is heterozygous, that means she is not carrying the pathogenic mutation there. And she is homozygous for interferon gamma receptor 1 gene, but we have to do a family screening, because this family appears to be a museum of mutation. We need to see what all homozygous or heterozygous mutations they are carrying. So parents, Sanger we have to do. Sanger sequencing of parents and Sanger sequencing of the eldest sibling who is 5 years of age. We have to do that. And then probably if the sibling is not carrying any mutation, she is, if a HLA matched donor, then this child can go in for a transplant. Otherwise, we'll have to look for a unrelated donor.
So till the transplant is done, do we have to give prophylactic antibiotics or AKT to this child?
So the child will continue on AKT, ma'am. So when you have an underlying genetic defect, AKT is continued for a prolonged period of time. We continue it for almost 2 years. We don't stop it. That's one. We have to keep looking for non-tubercular mycobacteria, Salmonella, Candida, Histoplasma, Leishmania, because these are all intracellular organisms, which are also the causative organisms of disease and Mendelian susceptibility to mycobacterial disease. So she can get affected by all these organisms also. So we will put her on Candida prophylaxis. We'll keep telling them that they have to drink only boiled water, not to go closer to animals and animal feces and all those things. Apart from, and the most important thing is No live vaccine when you have a elder sibling who has died in early infancy, had an HLH-like thing. We don't know what is the cause, irrespective of whether we have a genetic mutation or not. No live vaccine. Nothing will happen to the child if any live vaccine is not given. Because if you don't give OPV, if you don't give rotavirus, and if you don't give BCG, and the child after 2 months is proven to be absolutely fine and the exome sequencing doesn't show anything, we can then give the child everything. But the live vaccine causes most of the problems, and morbidity is because of the live vaccine, not per se because of the disease. Disease per se, yes, but the live vaccine causes more morbidity.
That's really enlightening, and we will keep this in our mind when we are practicing as a private pediatricians. Thank you so much, Dr. Vijaya, and thank you so much, Dr. Reshma.
Thank you so much.
Now we
Thank you.
move on.
Thank you very much. I welcome Dr. Pavan Sureka, senior pediatrician from Borivali. Pavan, would you like to say something? Today we have a galaxy of senior pediatricians. I see Dr. Murthy and Vijaya and Dr. Pavan. Dolly is, I think Dolly is there here, but I don't know whether she is going to comment something. Dr. Samir Sheikh, thank you so much, everyone. For yes, Pavan, you want to say something about BCG?
No, I think Dr. Reshma and Dr. Vidya Kori have already highlighted. There's nothing more to it.
Thank you, Pavan, for joining.
So much, Dr. Pavan. Now we move on to our next speaker, who is very famous.
But is he there? Has he joined?
Yeah, we have to. Otherwise, we'll ask Vaishnavi to.
Yeah. I don't think Dr. Naresh is there. Join. Dr. Naresh? I don't think Naresh has joined. Jayashree, I'll give him a call. You can ask Vaishnavi to present.
Okay, Dr. Vaishnavi, are you ready?
Yes, ma'am.
You're on mute.
Can I start? Ma'am, I can't hear you.
Jayashree, you introduced.
You can start, madam. Hello, Dr. Vaishnavi. She is presently working with Dr. Shailesh Bharon at Ankul Hospital.
Shall I start, ma'am?
Vaishnavi,
start now?
you can like share your slides with Dr. Pallavi if you want to, so that she can project them for you.
Can I directly share my screen?
Yeah, that's good. Yeah, that's good.
So this is a case of 25 days old male child born of non-consanguineous marriage. He was brought with complaints of cough since 5 to 6 days, increased work of breathing since morning, not taking feed since 1 day, and decreased activity. Birth history wise, antenatally, the mother had GDM and PIH and was on oral medication. The baby was full term LSCS in view of uteroplacental insufficiency. IUGR with a birth weight of 2.2 kgs, cried immediately at birth. Past history wise, the baby on day of life 3, the baby was lethargic, hence IV access was taken and the baby was shifted to government hospital, where the baby received phototherapy for 2 days and was discharged by day of life 6. Post that, baby developed multiple abscesses on the right and the left forearms. Hence was again admitted on 16th of March, where IND was done, and on the same day the baby was discharged on augmentin. The pus culture which was sent was suggestive of MRSA, and hence syrup linezolid was added. So further on presentation, the baby, when we received the baby was hypothermic, had acrocyanosis and cold extremities. Vitally, the baby's heart rate was around 160. The baby had shallow respiration and RR respiratory rate was 30. BP was 67 by 31 and CRT was delayed. It was more than 5 seconds with an saturation of 75% on blue net. So on a system-wise, the baby had bilateral preps and distress was present. A soft systolic murmur was present. Activity was extremely poor, morose, suck and grasp, everything was absent and the baby did not respond to painful stimulus as well. So this was the initial ABG that we had done. So the pH was 6.7. There was a mixed respiratory and metabolic acidosis, severe respiratory and metabolic acidosis. So we did an initial resuscitation. The child was put on mechanical ventilator and also on inotropic support, that was dobutamine. So investigation, this was the initial X-ray post intubation. So the child had the baby had bilateral haziness, opacities in both the sides, more on the left side. Investigations were suggestive of raised WBC counts, 64,000 and a raised CRP of 64. The OTPT were also deranged. So we did resuscitate and then we initially started the baby on Zosyn and amikacin and vancomycin. So after that, once the baby was put on ventilator, the baby had frequent desaturation episodes, every time requiring suctioning. So on examination, we noticed that the ET secretions were quite thick and yellowish. So we did a serial monitoring of the baby and also the reports were done, which was suggestive of rising CRP. So that is why we upgraded the antibiotics to meropenem after 48 hours. So this was the X-ray on day 2. So we noticed that there were thick ET secretions and the ET was completely blocked. The left side of the lungs had completely collapsed. So at this time, we had to actually re-intubate the baby. So this was post re-intubation when, the left lung had slightly inflated. So these were the serial investigations. You can see the CRP was rising. This was on day 2 and this was on day 4 of admission, 213. So this is where we decided that we'll upgrade. And at the same time, when we had re-intubated the child, we had sent for an ET culture. So at the same time, we did a USG chest, which was suggestive of left lung consolidation with a well-defined hypoechoic lesion measuring 4 into 3 centimeters in the left lower zone, which was pushing the lung segment inferiorly. So we couldn't actually make out whether it is a collection or a mass. That's why HRCT was advised. So we could see some amount of collection there though. So we did a tapping under USG guidance where we could actually aspirate thick pus around 13 ml, which was also sent for culture. So this was pre aspiration basically. So and then this was the pus color that we actually aspirated, and this was post aspiration. There was some amount of hydropneumothorax that had developed. So we actually got a HRCT to know what exactly is going on. So this was the HRCT report. So we got small areas of consolidations with surrounding ground glass opacities in the right lung and peripherally enhancing collection in the posterior segment of the right lower lobe with air fluid levels and communication with bronchia suggestive of abscess. And also we had a large peripherally enhancing collection with air fluid level involving the entire left pneumothorax, causing compression of the upper and the lower lobes, which was suggestive of left-sided gross empyema with hydropneumothorax with the possibility of peripheral bronchopleural fistula in the left lung. So these are the CT. We have just highlighted the ones where you can actually make out the fistula. So this was the fistula, which was there. There is a fluid-filled cavity on the right side. So these are the ones.
Fluid-filled cavity on the right or left side?
Ma'am, there were both sides. So the left side was larger because it was compressing and also there was a bronchopulmonary fistula. So the connections were seen as well on the right side with the bronchia.
There was an abscess on the right side as well.
Yeah, but it was not as big as the left side. Matlab, we actually drained we actually aspirated from the left side itself. Now we did not touch the right side. So after the HRCT, because the lungs were completely diseased, both the sides, a joint meeting with the parents along with the surgeon and anesthetist was done, and the risk-benefit ratio of the surgery was discussed. So it was decided that we would go along with the conservative management because the morbidity of the surgery was far greater than the child surviving it. And also, we were not sure whether or not there was actually a bronchopulmonary fistula. So even if we had put in an ICD, an underwater seal would have just made the recovery longer. So we decided to stick to conservative management. And at the same time, we got the pus culture and intraculture reports, which were suggestive of MRSA, susceptible to vanco, genta, and clindamycin. So we upgraded the antibiotics accordingly. So we added on gentamicin and clindamycin at this point, and amikacin was stopped. So we did a repeat USG chest, and we did a total 3 tappings under USG guidance. So the first, that which I have already showed you, we had tapped around 13 ml. The second was done on 7. I'll show the X-rays also with this. So on 15 ml we had tapped, and the last which was done was on the 10th, which we had tapped 18 ml. So this was the time that we had done a second tap, where we had removed 15 ml. Sorry, this was the time we had actually done a second tap, and we had removed 15 ml of pus, because we had seen that the left side was completely consolidated. And this was the third time that we had done the tap, and we had removed 18 ml of pus. So as the baby was gradually doing better, vitally he was better, he was afebrile, color had improved, the activity had improved, the baby was extubated on day 7 of admission, and the baby maintained well on room air. So this was the course of antibiotics during the whole stay. So we had started with zosine and amikacin and vancomycin, of which we upgraded to meropenem, and zosine was stopped. And once we had upgraded to gentamicin and clindamycin, we had stopped amikacin. So these were the only antibiotics the baby had received. But due to financial reasons, the relatives had to take Dama to get admitted to higher center, or the arrangements were made for further management. But somehow, under some circumstances, the baby did not get admitted and went home with no further treatment. So when we came to know about this, we actually called the baby for follow-up, but they only showed up after 10 days. And miraculously, the baby was found to be recovering very well. So this was the X-ray. This is the very recent X-ray. We had just got it done yesterday. And this is like, the chest is completely good. The USG we had done, it came out to be completely normal. The investigations were within normal limits, and the child, this is the baby, completely healthy, with good activity, no distress, maintaining well. So this is like, the baby couldn't even complete the whole course of antibiotics, and yet with so much in both the lungs, the baby got recovered, which is actually a miracle. So this is basically the gist or the morale of the story.
Just too good, yaar.
Indeed, God is great.
God is great. Yeah. Did you?
Yes, are present in this gathering. Would you like to comment on this case? Dr. Murthy, Dr. Samir?
Yeah, Vijaya. Dr. Vijaya is here. Please, I think she should say something.
It can still be CGD. What she is, and it
Please,
can.
yeah, please do comment, Dr. Vijaya. She has said NBT advised.
Yeah, ma'am. So looking at the history, and when you are looking at the first baby's counts, the baby count was more than 60,000 or around 60,000. But of course, it is not a predominant polymorphic nuclear leukocytosis, which we expect in a leukocyte adhesion deficiency. But I would still like to know what was the day of cord fall in this child. Was the cord fall more than 14 days or less than that?
Cord fall. When did the cord fall up? Umbilical cord.
We don't know, madam,
It was,
exactly.
if we are not exactly sure, but they did not give any particular history of delayed.
We will find out.
Bleeding
So
post.
that is something which we need to find out.
Yes.
What is the day of cord fall?
Why, lady?
Yeah, so day of cord fall is one. History of omphalitis, if anything, noted when you saw the baby. But by the time the baby came to you, it was quite late. And the baby had already received some treatment. So omphalitis is something which will give us a idea whether we are probably dealing with a leukocyte adhesion deficiency. And partial LAD. A partial LAD can present with LAD type 3, can have a count, continue to present a little late. The cord fall can also be early or normal. So these are things which are little pitfalls here. So they might not present with a classical history, but we should always keep phagocyte defect in our mind when we isolate MRSA. That's a dictum which Dr. Mukesh Desai tells us. Why should a baby have a community acquired staph which goes to an extent that it develops into an empyema when maternal antibodies are there in baby's circulation? If that is there, then there has to be a reason why this has happened. So we should always look for phagocytic defect because Staph aureus is a common organism with phagocytic defect. So one is LAD and the second is a CGD, chronic granulomatous disease. So at this juncture, now that the child is all right, we can go back, revisit them and ask them when was the cord fall. We can just keep the child on follow-up. We can send a NBT DHR at least to see if everything is normal.
We can refer this child to Vadia. For Dr.
Madam, already
you can
we
refer the
refer to
child to Vadia,
Vadia.
or you can send
Already we referred this patient to
EDTA
Vadia.
and heparin sample to NIIH.
But the
Yes, sir.
child didn't get admitted. They didn't admit that
No problem
child.
at all. So
That's why the
what I
patient
would
came
suggest,
to
sir, is if you can send. Okay, sir. If whenever the child comes to you, if it is a Monday or a Thursday, you can send EDTA and heparin sample to NIIH KEM 13th floor. EDTA and heparin sample for NBT and DHR with this history.
Yes, madam.
Yeah.
Madam, already we took sample and already planned for that. But then the relatives refused to do anything else. That's why we stopped at that time. But we will definitely go for this. We will contact
so that would
again.
be the simplest thing, sir. That would be the simplest thing. And if it works out normal, then at least we know that we have ruled out one phagocytic defect at least. LAD still we have to keep our fingers crossed and see if the child develops into another abscess or not.
Okay, ma'am. Definitely.
Superb. What a lovely case. What lovely learning.
Hello. Am I?
Yeah, that
Dr. Vijaya's comment is very important, and I think she will give you a definitive diagnosis for this patient, and also she will ask us to repeat for any other sibling should not suffer or from such diseases henceforth. Now we welcome Dr. Naresh Biani.
Someone else, Jayashree, I think someone else wanted to make a comment. I'm not sure.
Hello.
Someone else
Anybody wants to talk on this case?
Manohar?
No, madam. No, nothing.
So now it's my great pleasure to welcome Dr. Naresh Biani, the world famous pediatric neurosurgeon from Bombay Hospital and Vadia Hospital. When he says anything unusual, it's really something we should learn from that. Welcome, Dr. Naresh Biani, sir.
Yeah, thank you very much, ma'am. Good afternoon. There was some miscommunication, but it's all sorted out. What I wanted to present was an antenatal case, and how a pediatrician should go about it, So I just wanted to know which is the most commonest antenatally diagnosed neurosurgical problem that obstetrician sees? Any guess?
Hydrocephalus,
No.
meningomyelocele.
No.
Arey?
That's the googly actually, ma'am. Okay.
Arnold Sherry, no.
No, Arnold Cherry is a secondary thing.
Yeah.
So basically, it's a fetal medicine team that is involved with the obstetrician, radiologist, pediatrician, and pediatric neurosurgeon. I'm talking about a neurosurgical problem. Okay.
Maybe Anjali.
No, this is a slide actually, So in 2017, what they had found out was that the posterior fossa cyst anomaly was the most commonest of the antenatal defect. Okay. The second was corpus callosum agenesis. Okay. So I'll go through certain theory part of it and then we'll go by the examples, So the question that the family has, suddenly you will have a deformed child, number one. Current status is that up to 24 weeks, we have a medical termination of pregnancy. And then there are parents who have a lot of questions to ask, So what happens is that the obstetrician refers to a pediatrician. और pediatrician को भी पता नहीं, वो भी Google search कर रहा है, क्या करने का बोल के. And that is where the dilemma comes into picture. When we talk about antenatal consultation, the main is that the prospective parents comes to know about the disease process and its long-term outcome. The prospective parents and the team also develop a rapport where a decision for lifelong consequences for both the family and the child is taken care. And they also know that the treatment is available after the delivery. It is not like we deliver the baby and then abhi leke bhago. जहाँ पे भी NICU में bed मिल रहा है, municipality, government, and all those stuff, that doesn't happen. The child is delivered in a controlled fashion and appropriate treatment is started. Okay, so today I'm just going to talk about posterior fossa cyst that we see. Okay, this is what I mentioned earlier as well, So that's the most commonest anomaly that we see, But yes, it is not known. Any example that you have heard of posterior fossa cyst? Nahin? Dandy Walker malformation, pouch of Blake cyst. Okay, so these are the things, But the most commonest is cisterna magna. Okay. So the investigation tool that we have got is an ultrasound. That's a real time. It avoids the radiation. It is available, freely available all over the places, It's very sensitive. And now we have 3D images. And then when we have a doubt, abnormal USG, then a fetal MRI is asked for, Okay. So now cyst in the posterior fossa, if we understand the anatomy, the posterior fossa would have a midbrain, pons, and medulla. That's the brainstem. And then the cerebellum. Okay, this is a vermis. This is a middle part of the vermis. So upper vermis and inferior vermis. And then the phi area that you see is the cisterna magna. Okay, up to 10 millimeter of cisterna magna is normal. Okay, so if a child, if an antenatal scan comes with a 9 millimeter cisterna magna, then that is not at all abnormal. Okay, so the four commonest things that we see is a mega cisterna magna. That is almost 45% of the abnormal UHGs that we see. Then there is a Dandy Walker malformation and variant that again accounts for almost 45% of the thing. And then 5% would be pouch of Blake cyst and posterior fossa arachnoid cyst. Okay, so this is how the fetal MRI looks like. So here you have a brainstem, you have a vermis. Okay, this is a tentorium, and this is a cystic space, that is seen in the fetus. Little bit of embryology to understand, so that we can prognosticate the diseases also. So what happens is that at the midbrain, the rhombic limb, that forms, they combine and forms the roof of the fourth ventricle. This is the ventricle and this is the roof of the fourth ventricle. And this rhombic limb only forms the cerebellum and vermis. And Dandy Walker, what happens is that there's a cystic, there's a posterior fossa cyst that communicates with the fourth ventricle. So there is a non-fusion of the rhombic limb. If you understand that, then we know the embryology also. Rest of the things are very easy. Okay, so the vermians development I've spoken to you. Yeah. So another thing that we need to understand is this one, This is tegmento-vermian angle. Okay, the angle between the vermis of the posterior cerebellum and the brainstem. Okay, and normally it should be less than 18 degrees. Okay, here it is slightly more open, and then there is another angle that is called as tegmentum tentorial angle. Okay, in the tentorium. Okay, these are another two surrogate markers that we see. So next time, if you see any antenatal consultation with cyst in the posterior fossa, you need to ask for the radiologist what was the tegmentor-Vermean angle and what is the tegmentor-tentorial angle. Okay. So this is how it looks like. And these are the values. You can take a snapshot, or I will give you the presentation at the end of the thing. I'll load it in the PDF format. So at 20 weeks, the tegmento-Vermean angle normally should be less than 18 millimeter. If it is more than 18 and less than 30 degree, then it is called as pouch of Blake cyst. And if it is more than 40, it is part of a Dandy-Walker malformation. So it's so easy. The moment you see one entity, you can diagnose and prognosticate the process as well. Okay, and then the second angle that I called was the brain's tegmento-tentorial angle. So by tentorial, this is a surrogative markers. I'll show you some cases, and then it becomes more visually impressive. Okay, so normal cisterna magna is 10 millimeter. Anything more than 10 millimeter is known as cisterna magna, mega cisterna magna. Usually like 13 millimeter, 14 millimeter, but they are all absolutely perfect with long-term survival. And in all the cases of mega cisterna magna, the vermis is normal. Okay, the posterior fossa is normal. Okay, and the cyst doesn't communicate with the fourth ventricle. So very simple, you have a cyst in the posterior fossa, the vermis is normal, all the posterior fossa structures are normal, all the angles are normal, and the cyst doesn't communicate with the posterior fossa or the fourth ventricle. If you find this, you can safely label this as mega cisterna magna and very good prognosis. Okay, nothing to worry. Okay, now comes to the second commonest thing that we see is a pouch of Blake cyst. Okay, so what is that? So what happens is that as the cerebellum is being formed, the inferior vermis gets upturned because of the cyst that communicates with the posterior fossa. And during the pregnancy, this cyst wall ruptures and it disappears. Usually that disappears by around 28 weeks gestation. Okay, so again, this is a temporary condition that is transient condition that remains during the antenatal phase, and it disappears or it ruptures by itself by around 28 weeks to 30 weeks gestation. And again, this is a benign entity and nothing to worry. There is no Vermean abnormality, there is no posterior fossa abnormality, and there is long-term prognosis is good. Okay, so pouch of Blake cyst. So there is a outpouching from the fourth ventricle, and when it outpouches, it upturns the ventricle as well. Okay, and it is basically in the midline, so it is from the foramen of Magendie. Okay, and how can we identify this antenatally? Is that the tegmento-Vermean angle is more than 18 degree, but less than 30 degree. And if we have a sonologist who is very good in antenatal scans, they can see the choroid plexus also, the red thing that we see, So they can see that choroid plexus, and that is slightly upturned. So this is a transient condition, and suppose the next antenatal scan is done, and that would have disappeared. So sometimes, the family is also in a state of shock. Obstetricians are, "Arey, ye dikh raha tha aur abhi kidhar chale gaye?" So we have to tell them, no, this is a transient condition. Okay, pouch of Blake cyst. And now this is a most complicated one, Dandy-Walker malformation. Okay, so Dandy-Walker malformation, when we call that as Dandy-Walker malformation, there are 4 conditions that 6 conditions that has to be satisfied. Okay, what are those things? There is a big posterior fossa cyst that communicates with the fourth ventricle. There is a Vermean agenesis along with cerebellar hypoplasia or aplasia. Then there is an attended hydrocephalus. Because there's a cyst during the growing phase of the child, the posterior fossa volume is big. Okay, since the posterior fossa volume is big, the tentorium becomes more obtuse. Okay, and the junction of the superior sagittal sinus, inferior sagittal sinus, and the circular sinus, that is known as trocula, is moved away from the foramen magnum. So basically, last three conditions are the corollary for the large posterior fossa. Okay, so suppose you find all the 6 conditions in a child, then it is Dandy-Walker malformation. And suppose you find any of them, 2 of them or 3 of them, then it becomes Dandy-Walker variant. So it's very easy. Okay, the main thing is that there is a posterior fossa cyst that communicates with the fourth ventricle, and when it communicates, the vermis is not formed, and you have a vermian agenesis. Okay, and then there is an attended hydrocephalus and all those stuff. So this is how we can differentiate. This is the normal, and there is an inferior vermis aplasia. So the choroid plexus moves out. Okay, this is the antenatal schematic scans. Okay, and this is how the child the scans look like. There is a medium size, and this is a quite large size. Almost the half of the brain is also there. Okay, and when we take an axial cuts, we don't find the vermis. You should be finding a vermis structure in the midline. So that's absent. Okay, coming to the last entity, posterior fossa arachnoid cyst. That is the posterior fossa cyst that doesn't communicate with the fourth ventricle. You have a normal size cerebellum and vermis. There is no displacement of the cystic lesion, and all the angles, the tegmentovermian and tegmentotentorial angle are all normal. So basically, you just find a cyst in the posterior fossa, and that is usually eccentric also, laterally. Okay. I'll come with few examples. So now there's a 22-week antenatal consultation where that report says that there's a megacisterna magna. Okay, it's a cisterna magna is 13 millimeter. Naturally, they repeat a scan done, and at 28 weeks they tell that there's a vermian hypoplasia, no hydrocephalus, and probably it is a Dandy-Walker variant. And that is a big dilemma. What to do now? What would be the prognosis? Okay, and we have crossed the age of safely terminating the pregnancy. Okay, so now after all these things, what would be the counseling thing, or do you want anything more in this?
Do you want the picture?
Picture antenatal देखता हूँ. हाँ, ये है.
छोटा है. Prognosis may be good.
We don't go by the sizes. Basically, we want to see the angles, basically, ma'am. So if there is angles are normal, then the prognosis is good. Okay. So this is the child that was delivered. Okay. Then this is the postnatal scan. Again, this was the megacisterna magna or Dandy-Walker variant that we had found that. Okay. So it has a good prognosis. So from an obstetrician point of view, they are worried, whether they can deliver at their own nursing home or a care center, where there is a NICU. It is not that the child would be rushed to a neurosurgical intervention immediately after the birth. In fact, after the delivery, if the child is all normal, we just do a postnatal sonography, and this imaging is also done at 3 months of life. Okay, that is also not done immediately.
So no neurosurgical intervention.
No, not at all.
Never.
So it was no, not never. In this particular case, it was a Dandy-Walker variant.
Yeah. So
and didn't
in this
require
case, never.
anything.
Yeah.
No. Okay, child has a good prognosis and all those stuff. Okay. So another one, 28 weeks gestation, was diagnosed as hydrocephalus, and then there was a vermian hypoplasia and Dandy-Walker malformation. And this is how the antenatal scan looks like. So this is the skull. You see there is no vermis, and then there is a big cyst occupying the posterior fossa. Okay, but when the child was delivered, the child had encephalocele also. So whenever we see any antenatal abnormality, we have to forewarn the family. Whatever we are seeing in ultrasound is might be some attended abnormalities as well. It is not foolproof. So if somebody would ask, how was this encephalocele missed? It was because probably the child's head was compressed towards the uterus, and the sonography, what they find is that there should be a difference, acoustic difference, in the echoes. That is when the things are picked up. So if this encephalocele was filled with water, so it would not picked it up also. Okay. So this child is born with a large head, Dandy-Walker malformation, and an encephalocele. Immediately a CT scan is done, and this is what the scan looks like. So basically, it was just a meningocyte. It was not having any brain content. Okay. Any what would be the time scale for the treatment?
Immediate.
Correct. Once a couple of days are formed, we rule out that there is no other major systemic abnormalities, RS, CVS, and GIT. And then the child is subjected for surgery. So what we do is we put in a shunt first because there was a hydrocephalus. And once the shunt is put, all this encephalocele repair is also done. Okay. Okay. Only thing that I want to forewarn you is that I have seen 5 Dandy-Walker malformation that were diagnosed antenatally, were delivered in a tier 2 NICU setup, but they had a brainstem hypoplasia also, and they remained ventilator dependent as well. So when we see Dandy-Walker, it's very rare. I would put it like 0.5%, but as a precautionary measure, we have to tell to the family, that if that is associated brainstem abnormality or hypoplasia, then the child might need a ventilator also. Okay.
Harish, if this patient comes very early in pregnancy, like in say 20 weeks, and you see
Yes.
a cyst, would you advise termination?
Yeah. So now, what were the rules of termination? So medically terminating the pregnancy, if there is any abnormality, and if the family doesn't wish to continue the pregnancy, then there is no question of discussion also. The question comes is that when the family wants to know if my child is going to be normal or abnormal, okay, if they wish to continue the pregnancy. So now there is only one study from France, actually, Paris group, where they have told that inferior vermis, absent of inferior vermis antenatally at 22 weeks gestation, they have seen without hydrocephalus or without other abnormalities, is that medically retarded children is 60%. Okay. And 40% are normal. Okay. So if you ask a pediatric neurologist, what would be the outcome of a Dandy-Walker malformation, they would say that it's a very bad outcome and all those stuff. So this we call them as an survivorship bias or anchorage bias. So the children who come to me are all good. They need a surgery. The mentally retarded or delayed milestone people would not turn up to me.
Come for surgery.
Yes. So there is always this bias. But if you ask a neurologist, so the moment you tell him, no, I'm seeing an antenatal child with a Dandy-Walker malformation, they also start getting shiverings, because you don't want to take a chance. Okay. The moral of story is that at 20 weeks gestation, nobody can predict the long-term outcome. So during the antenatal counseling, we give them all the statistics and let them take a decision. Okay, you don't force them for a decision. We should help them in guiding and coming to a fair conclusion. मजा क्या आता है कि फैमिली कभी कभी बोल देती है कि अरे आपके घर में किसी को होता है ऐसा, या आपके क्लोज रिलेटिव में किसी को होता, तो आप क्या गाइड करते? So that is again a googly, that is very nicely bowled by the relative, and we should be a nice batsman to handle that also. Okay, the easy thing that I tell them is that I am a vegetarian. I don't eat non-veg, but somebody who is eating non-veg is not bad. Okay, so it's all person to person. Something that is good for me might not be good for them. Something that is good for them might not be good for them. But at the end of the day, it is their baby and they have to take a call. As a clinician, as a pediatric neurosurgeon, I can come them to give them all the explanation and help them to come to a conclusion. But the decision that continue or discontinue the pregnancy would be purely theirs.
But a 60% abnormality is a very large percentage.
It's a big one, especially in India. See what happens in abroad, that the state takes care of the health thing, So even if the child is crippled, there is an institution they can take care of the baby, So the family, it is not burdened. But in India, it's a big socio-economical burden also that comes with the picture. Okay. So now suppose मैं आपको उल्टा बोलता हूँ, we get a scan done for head injury, and then we see that there's a Dandy-Walker malformation and the child is perfectly well, So we see a lot of these cases where you have incidentally found out, Dandy-Walker malformation or corpus callosum agenesis or a small arachnoid cyst and all those stuff. Also, so you have a surgical condition that are very mild and are perfectly well with the normal survival of the child as well. Okay. The question again, the double googly comes is that when there is a bad obstetric history or an IVF child, where the obstetrician wants to continue the pregnancy, they are very committed and they are very, very emotional about it, and then we have to take a call on that. So given the thing, luckily now, that the termination time has been increased to 24 weeks. नहीं तो पहले तो 20 weeks पे ही होता है और वर्मिस बनता ही 22 से 24 weeks पे. So it used to be a very big dilemma, but now we are slightly lucky. Okay. And what I would say is that when the obstetrician refers to a pediatrician, better to tell, मैं तो pediatrician हूँ, मेरे को तो इतना आता नहीं. Why don't you take a consultation from XYZ or ABC person, the consultant people? So that also makes a relieving factor for both obstetrician also and pediatrician also, because they have not primarily taken a decision. Okay, I know few pediatrician from say Kalyan and all those stuff, they told that, okay, you continue the pregnancy, and then the family would every time turn up with the family. हम तो नहीं कराना चाहते थे, आपने बोला इसके लिए हम कराए. So you never know, how the family is going to turn up also. So better to be on a safer side and talk with a sense, with the literature. Okay, so now we have a doctor couple who have 30 weeks gestation, and it's found to be a dandy walker malfunction. Okay, they got a fetal MRI done, and you see, it's a large posterior fossa cyst, no vermis, okay, and attended hydrocephalus also. And from some religious reason, they don't want termination; they just want to continue the pregnancy. Okay, so what would be the prognosis?
Vermis is small, so the prognosis is not good.
Vermis is not seen only, ma'am.
Not seen now. So it's not a good prognosis.
Yeah, so that is what is the common sense that tells us. Okay, so this is a fetal MRI. There's a small amount of vermis that is seen, inferior vermis is absent. Okay, the child was delivered. This is the postnatal scan. Okay, so we see some remnant of tissue over here and then the vermis. This is a posterior fossa cyst. A VP shunt was put in. Okay, so this is pre-VP shunt, and this is the post-VP shunt, cystoperitoneal shunt. And you see the whole posterior fossa is again regenerated also. Okay, the child is perfectly normal. She is now 8 years and doing absolutely fine.
Fantastic.
नहीं, fantastic नहीं. इसमें ऐसा रहता है कि the cases that we see think that it is very bad. Also, means the God or nature is very kind, sir. It's always surprises. And these are a doctor couple, from Bhaikla. और वो तो इतना निश्चय, दृढ़ निश्चय था कि आप हमको फालतू में डरा रहे थे. हमको तो मालूम ही था बच्चा अच्छा ही होने वाला है. And all our medical knowledge and experience goes to a toss actually, Okay.
Child was amongst that 40%.
I don't know, ma'am. Yes. But what I believe is that we should give one good attempt to the child, If they come to us for a treatment, we should give them one good attempt. Okay. 28 weeks gestation, posterior fossa cyst. Again, here you see this, there is a absent vermis and then a large posterior fossa cyst. Okay. And now this child had an attended corpus callosum agenesis. Okay. And also the colpocephaly. Okay, so here the prognosis is bad. They wanted to continue the pregnancy and all those stuff, no hydrocephalus, and it's fine, it's their baby, and if they want to continue, we are nobody to decide about that. But from our point of view as a doctor, when we are doing an antenatal consultation, we make sure that all the other abnormalities are also ruled out. Okay, this is the last one.
Child do? How was that child maintained?
No, this was with the follow-up with the pediatric neurologist. मीन्स हमारा भी क्या बहुत बड़ा बायस होता है मैम, जो सर्जरी केसेस रहे वही मैं बता सकता हूँ.
So this child was not operated for anything.
No, that doesn't. So again, another very important thing, the obstetrician is always worried, that अरे पैदा होएगा बच्चा इसके बाद में immediately surgery लगेगा. No, not at all. Even if the child has a gross hydrocephalus, because all the 6 sutures are open and the AF is large and wide, we can easily wait for 7-8 days. Okay, what I would prefer is that wait for at least 3 days, let the child develop the nice hemostasis, let all the organs are checked up, and then we can do that, Or sometimes, physiological jaundice also comes and goes away. So we don't want to stress the baby with that, Okay, if the front end is all open and a compensated hydrocephalus, the child doesn't crash us. पर उनको कैसा डरा देते हैं कि डिलीवरी होएगा इमीडिएटली 2 घंटे में सर्जरी नहीं करेंगे तो बच्चा ही नहीं रहेगा. And that is not bad. That is not good enough.
True.
Okay. This is another antenatal scan, where you can see, there's a cystic lesion in the back here, transcerebellar. Okay, a fetal MRI was asked for, and you see there is a cyst here. Okay, and the vermis is fully present. And here what is happening is that the cyst is compressing the vermis from back. And the cyst is eccentric, on one side. Okay, it is not communicating with the fourth ventricle. So what is it now?
Subarachnoid cyst.
Correct, posterior fossa arachnoid cyst.
Posterior fossa.
Yeah, so this is how the child, this is a scan done at 3 months of age. Okay, again, there was no hydrocephalus. Okay, the child was growing well. So the child was kept in observation. And after 6 months, the compression increased. And you can see, this was the ventricular size. And here the ventricular size had increased. And that is when a Y shunt was inserted. Shunt in the ventricle and another shunt in the posterior fossa. Okay, so again, even if some abnormality is diagnosed at antenatal scan, it is not that the child would undergo a surgery immediately at birth, Okay, we can safely wait also, Sometimes कैसा हो जाता है कि 2-tier city, 3-tier city में रहते हैं, उनको इतना डरा देते हैं कि डिलीवरी तो आपको टर्शियरी केयर सेंटर में ही करना है, नहीं तो पॉसिबल ही नहीं. So that we can be very, very forceful and can tell them,
But Dr. Naresh, this was not communicating with the fourth ventricle.
No, this is not. Posterior fossa arachnoid cyst would never communicate with the fourth ventricle. Okay. You can see the whole vermis also, ma'am.
Yeah.
And it is getting compressed. Suppose there was a cyst over here, the vermis would have upturned, it would have rolled over, These are little bit things, but definitely it helps us in coming to a right diagnosis. Okay, there's another posterior fossa cyst. Okay, you see this here? Oh, sorry. Okay, now the angle is normal, the vermis is full. Okay, there's just a posterior fossa cyst that is communicating with the fourth ventricle. So what is this?
A cyst.
That is a pouch oblique cyst actually, but that has not, pouch oblique cyst that has not ruptured.
Yeah.
Okay, so I have given all the examples, like
so
6
this
cases
pouch
and
of
example. Blake cyst.
Pouch of Blake cyst is also like a Dandy Walker variant?
No, it is a totally different entity, but in this particular case, it had not ruptured. Very rare.
Okay.
Okay, Dandy Walker, to quantify the Dandy Walker, the inferior vermis has to be absent.
Got it. Got it.
There are two things,
Yeah.
Okay, so now take home messages.
Surgery?
Pardon, no need of surgery, sir.
Okay.
बहुत रेयर होता है, न्यूरोसर्जन सर्जरी नहीं बोल रहे हैं. Okay, take home messages. So we need to know what is posterior fossa arachnoid cyst. There are basically 4 diagnoses. Cyst in posterior fossa, Vermian agenesis, and means when you see antenatal scans, these are the things that I would like, to know, whether the cyst communicates with the fourth ventricle or not. What is the vermis and cerebellum looking like? What is the posterior fossa volume? And what is the brainstem vermian angle and brainstem tegmentum or brainstem tentorial angle? So next time, if you see that, you should always ask for all these things. And if this antenatally, these reports are missing, probably we can pick up a phone and talk to the radiologist also. Sometimes what happens is that the radiologists also do it in ghai mein kar dete. Okay, but any person who is doing good fetal anomaly scans would have definitely mentioned all these conditions. That is a part of a antenatal scan. Ek minute. Come kar, volume come. Okay, so there is a good outcome if appropriately treated. Okay, not all intracranial abnormalities have a bad prognosis. होता कैसा है, the moment anything intracranial comes into picture, abnormal antenatal scan, the obstetrician starts sweating. Naturally the pediatrician भी बोलेगा कि कल को मेरे घर पे आके काय को वो चिल्लाएगा, जाने दो ना वो. Okay, so apples are apples, oranges are oranges. Okay, thank you.
Thank you so much, Dr. Biani. So apples and apples and oranges, and your
Lovely
wisdom is
presentation. Thank you. Yeah.
exclusively good for all of us. Thank you so much.
Yeah.
And I always say this God is great again.
Yes, yes. There's always a supernatural power who is taking care of us, and we are nobody actually. Ma'am.
Superb, superb. Something very unusual. We have never had a presentation like this, Dr. Naresh. Thank you so much for all that.
नहीं मैम I had just actually there was some confusion because in the group they asked who is going to present, and I had raised my hand, and unfortunately I have not seen my thing. They are very interesting. Maybe next time if somebody is not presenting, you just let me know. I'll keep myself free. So we have this antenatally diagnosed ventriculomegaly or antenatally spinal dysraphism. Lot of things. There is something new for a pediatrician.
बात पक्का ही समझो जी. बात पक्का समझो. आप next time
हम खाली एक इशारे के लिए तैयार है, वेट करते
हैं. बस तो आप present ही कर दो. So next time again on the 4th Wednesday of next month, the 4th Wednesday.
Sure.
Dr. We will keep a series of lectures actually.
Yes. So,
and we will learn from all whatever is possible from our side to learn from Dr. Biani.
Yes, ma'am. Yes, ma'am.
So पक्का बात पक्की समझो. Next, our next meet is next 4th Wednesday of May. I will send.
Yeah.
आप next half an hour में देख लीजिए. I will send you the date.
नहीं मेरा पूरा presentation तैयार है. अभी आप बोलेंगे तो अभी मैं वापस से रोल भी कर सकता हूँ. मेरे पास सब तैयार है.
No, we wait for next time. So yeah, great.
We should also be able to assimilate whatever you have taught us.
Absolutely,
and,
no, ma'am. See,
so
attention span is more than
sensitizing all pediatricians.
Yeah,
so please send your PDF file to us, and we will.
Yeah, I'll load it at the in the group.
Dr. Hemant Joshi wants to raise his question.
No, if we have spare time and if he has something to say, then we should utilize this time.
No, I have a lot of time, sir. ऐसा नहीं है. बाकी लोग को भी तो काम रहता है ना, sir.
Then I am requesting the organizers.
Yes, actually, we have time, and whatever is possible from your side, we are ready to learn, sir.
Keep it for next time, Jayashree. Hemant has to complete his.
Okay.
So it's already 4:30. We are 1.5 hours into this program, and our attention will wander. So we'll keep the suspense for next time and be all fresh to listen to you.
I used to share a lot of cases in the group, but there was no answer that was coming, So that made me think. Now I'll again restart.
I promise to share. Please, you send.
Yes, ma'am. There should be some active discussion and participation. Feel free to ask any question. Means when I share a case, I have already prepared it from means antenatal till the long-term follow-up. Ma'am.
Yeah. Please do.
We'll do that way. That would be better.
Yeah, and next time again we are meeting. So
yes, of course, yes, no problem.
Yeah. So thank you so much, Dr. Naresh Biani, for such an enlightening lecture. Now I invite Dr. Hemant Joshi, sir, to talk on the local epidemiology, your own experiences and your own area where you can have suggestion about the treatment, investigation, as well as the complication which you have faced in this month.
Thank you everybody for attending first and surviving all these cases. I am only opening batsman. We have a team of 44 players today. I request all of you to share your whatever good you know and you have learned in past that you can share, because sharing helps the one who tells. Summer is the problem. This year, the temperatures will be 5 degrees more than average. And there were 11 deaths at Palghar. There are two issues. One is summer. But the missed issue is that we are an overcrowded country. So if a bridge falls in Mumbai, many people die. You go to any tourism place and there is no place to stand. And it's foolish to go to any temple in India. You don't come back alive or happy at least. So we all must enlighten those who come to us when the new baby comes, we offer them with advice that they need for postponing a baby, because every third baby is born when the parents said that they wanted the baby, but not now. So still the right messages have not reached everybody, even the elite. So it's our job to be kind and help the country, because and India can support 100 crore people. We are already 150 crores. And we'll soon be 200 crores. And when the boat sinks, nobody survives. So we are already sinking. Somebody is dying in the train, somebody is dying in wherever. So two issues I have said. One, heat stroke. And second, we need to...
Population.
It's not government's job. It's our job as well. Number two. Number three, a guest came from Indore and said, my child has fever. So I said, you just hold the cheeks like this and tell me which is warmer. She said, skin is warmer. I said, your child is heat stroke. So go and bathe. So this is very simple. And every mother, when she feeds the baby, if the newborns suffer the most because we wrap them. If a baby gets fever and the mother feels the fever to the hand first, it is heat stroke. And if she's feeding the baby and she feels while feeding that the mouth is warmer, first fever, where was it felt? Then that is a fever like viral fever. And Dr. Amdekar said a very good point. Touch the feet of the baby. If the baby has fever and the feet are cold, it is illness. If the baby has fever and the feet are warm, hands are warm, it is heat stroke. And the heat stroke guys, you touch their neck, it is dry. And they are thirsty and they are playful. So how do you diagnose heat stroke? Why am I telling you this? 633 out of 1,200 admissions in 2 years in our pre-COVID area, where because of this fever, they did not need antibiotics. They just became already with fluids. And many of our OPD patients do have this. So when a patient comes with fever, if he's playful, it is heat stroke. If he is passing less urine, it is heat stroke. They can come together as well. First, I'll just tell about heat stroke. If the skin is dry, see the neck would be wet. Ask the mommy to see her own way, neck, to teach, and then see the baby's neck. And another thing is demonstration is the best thing to do. Let them auscultate, let them see the black knuckles, let them see the flat nails, let them see the dry skin. If the fever child is playful, he has got heat stroke. If the skin is hotter than the mouth, which you can do by infrared thermometer or whatever way, skin and core temperatures, they pass less urine, their hands and feet are warm, and they are playful. They're not sick. And but they can come together. You can have malaria, typhoid, and you can still have heat stroke. In that case, when you hydrate the baby, the skin becomes cooler than the mouth. So that was one issue. Number two issue, I told you about population. Number three, I want you all to tell 1 point each. We are 45. And we all are wise people with a lot of years and gray hair. And the youngsters as well can tell. So you all are welcome to raise your hand and then tell us.
Actually, tepid sponging with cold water is a wrong way of treating any disease, but a lukewarm water sponge will help.
We have a bathroom in the OPD. So children just go and bathe. And we give them a lot of water and you don't have to dry them. They just dry away on their own. You don't need a towel. I invite you all to see our bathroom in the OPD. If anybody has anything from his experience, malaria, typhoid, this is malaria day is coming up, so somebody wants to say something.
We have been seeing a lot of follicular tonsillitis. I don't know whether others are also seeing, but I'm seeing at least 6 or 7 year old children with follicular tonsillitis. And very little of those adenoviral fevers that were there earlier last month. I don't know, yesterday there was a report in the news that said that pink eye is because of COVID and things like that. Did anyone see that? But, what adenovirus illness was, conjunctivitis and all this, and new cases of COVID with conjunctivitis. So I don't know whether that is true or that was some misconstrued and yeah, Dr. Hemant.
No, when in doubt, see, we do CRP, CBC, CRP, calcium, magnesium, blah, blah, blah. Test for COVID, no? Whenever.
No, I'm not.
Not even person. I'm just telling for
we are not seeing that. No, this was a TV news. So I'm everybody has seen and tested and proved that you have read about it recently.
No, but I want to tell you something else. COVID is really rising and there are deaths abroad.
Yes.
So
Yes.
if you see two eyes in the woods, deep woods, take it as tiger. If you doubt, you won't be there. And so let's be, it's our job as pediatricians to be conscious, careful, and miss nothing.
Yeah. So no, the general OPD has also reduced, not seeing so many of coughs and colds. And so I'm not sure that I'm seeing lots of COVID patients, but I did see two non-communicable diseases which struck me. Lots of children are now overweight, and we saw two cases with hypertension. They were both 10 and 12 years old. So it's alarming. So it's something that we have to be really, really aware of.
Yeah. Can I say something?
Yeah, please.
Yeah. So I'm talking about epidemiology. That is illness pattern of our country, right? Area. Dr. Deepak Desai is a gynecologist here. He said every second mother now is pre-diabetic.
Yes.
So we are making bad mother. If we are responsible up to 18 years, it is our job to make fit women. And so that they deliver normally. There is one state government which has now ordered audit of all LSCSs. You know why? Because the incidence of LSCS grew from 67 to 75%. But I'm surprised that I'm happy that they are alarmed. My daughter is in UK, so there, if the incidence of seizure is 25%, audit is held for that hospital. They are learning in that process. But we are, as pediatricians, we have failed to make healthy women. If there are healthy women, they are not fit to deliver a baby, sort of. And they have diabetes and they make bad baby. Number two. Number three, we are not careful about blood pressure. Let's celebrate birthday of every child in our clinic. Let us, I'm beginning with us. And take their blood pressure and they record it on their chart. Because a rise of 5 millimeters needs treatment, non-drug treatment. And the rise of 10 millimeters needs drug treatment, even for adults. But we don't know the base. When we say 120 by 80, it is an average. Means 49 people have less than that and 49 people have more than that.
Is
It's a
it
mean,
because
median.
of the salt intake which is increased in kids?
Okay.
Okay.
You have made the right point. But we don't know the basic blood pressure of our children. So for that child, that blood pressure is okay. Suppose he is 60 by whatever, suppose he is by 60. Then if it becomes 85, it is hypertension. If it becomes 65, it is hypertension. If it becomes 90 by 70, he needs drugs. We wait for 140 by 90. We are BP unconscious people. We don't know our own blood pressure. I will tell you my wife's incident. We went for our child first daughter's delivery. Her blood pressure was 90 by 70 or 90 by 60. And the gynecologist was alarmed. She'll need, she'll go in shock. She's so low. He called the senior at midnight. He said, don't worry, we'll wait till morning. Let's see what happens. And then we realized for her, the normal blood pressure is 90 by 70. But that was the hindsight. So we don't know our own blood pressures. So if my blood, anybody's blood pressure is 100 by 70, if he becomes 105 by 75, he needs non-therapeutic treatment for hypertension. And if he raises by 10, from 100 it becomes 110 or 70 to 80, then he needs therapeutic treatment. And if you wait for 140 by 90, that is how we are killing our people. So I'm talking from the doctor's end. And what she said was correct, that we need to eat, say, 3 grams of salt, maximum 5. But we usually end up eating 10 to 20 because in kitchen only we put by tons of salt in everything. All sweet dishes have salt, all sweet biscuits. So don't eat outside at all. And remove salt from kitchen and you take it from the tabletop dispenser, whatever you personally want. I'm done. Thank you.
Dr. Murthy.
I'll share a link on I'll share a chart, British pediatric chart, which is a growth chart like chart. Percentile chart for blood pressures from 0 to 18. And then you'll realize what I'm telling you now. Done.
Yes, Dr. Murthy. You're
Salt intake and this packaged food is a big menace. That is what we are trying to combat. And unfortunately, I think only since the past 8 or 10 years, we are seeing more of adolescents and pre-adolescents. Before that, we were more of, up to 8 and 10 years, and nobody used to come to us after that. So I think it's a daily battle we are all facing, trying to reduce the amount of salt and the chances of PCOS and all these things.
Yes, very true, Dr. Murthy. Raksha, you want to say something? Raksha? Well, there's Dr. Manisha Bowdekar as well. Manisha, you'd like to say something? Dr. Manisha? Girish? Dr. Girish, Dr. Manisha Bowdekar? Archana is still there online. Archana?
Yeah, she'll come. She'll join in 1 minute.
Anuradha, you want to share something from Tulenja Bolins?
Madam, we are not seeing lot of cases. We are seeing cases of measles. Still, we are seeing.
No, can't hear. Could not get that.
Archana is not coming. She's
Okay.
Madam, we are still seeing cases of measles. Which are non-vaccinated.
Oh my God.
Yeah.
Even chickenpox is there. Yeah.
3-4 days back, we discharged last 2 cases of measles. But in last month, I saw almost 7-8 cases of measles. They got admitted in Boling Hospital. And
measles.
We are seeing, yes.
You saw measles.
Bigger children.
Naturally.
Bigger like 13, 14 years children. They're ranging from 6 months to 14 years.
Anuradha, they were all from Virar East. Where were they?
No, madam. Mostly from Nalasopara.
Nalasopara East.
Yes, Santosh Bhavan area. Then mostly from Nalasopara, few from Virar, which were non-vaccinated.
Yeah.
All were non-vaccinated. And we are seeing few cases of dysentery, diarrhea, typhoid, pneumonia. That's it. Some are viral.
Dr. Manisha, are you there? Girish Sonekar, are you there? Dr. Raksha? Raksha, you're there? Are you? Anyone else wants to say? Girish, yeah. Hi. Yeah. Unmute yourself and make any comments, Girish. Yeah.
Hello, madam.
Yeah.
And nothing specific. What I saw was more of a chicken pox in last 15 days in April, actually, this April month. And measles cases, I saw less measles cases in April as compared to March.
Yeah.
That's what I will comment. Otherwise, gastro and
Yeah. Yeah. Hemant, yeah. And then Dr. Murthy. Yeah.
Yeah, we are getting a herpes vaccine. So
Shingrix.
As it launches, wise people will take it. Thank you.
Yeah, Shingrix. Today I gave 2 of my friends the Shingrix. I have taken it earlier. Yeah, Dr. Murthy.
Yeah, I was asking if people are still seeing these cases of adenoiditis with so much of mouth breathing and snoring. Is it still going on? I'm still seeing a few of those.
I'm not
so many
it.
last months. I'm still seeing a few of those coming. People aren't seeing that?
No, I haven't seen. Is anyone else seeing? Perhaps I don't see too many patients. But what about Anuradha, Jayashree, Raksha, Girish? Are you seeing adenotonsillitis as much as we were seeing in March?
No, they are not that. They have decreased, and most of, I think 30% of the population went to their native place.
Yeah.
That
OPD has gone down considerably. Yeah. Yeah. But still surprised that you are seeing measles and they are not yet vaccinated, because at least there should have been a primary round of MR after the breakout.
Yes.
Yeah, Dr. Hemant.
No, they are the anyway. They all have not gone to school, and they are all.
From single family, we are getting three kids, like 2 kids, 3 kids.
And also, just talk with the family.
Yeah, doctor.
Are these cases very bad, severe cases of the adolescents and older kids? Are they getting very bad, serious?
Anuradha.
Yes, madam. Yes.
Dr. Murthy is asking you that those children with measles, the 13, 14-year-old, are they very serious?
No, madam. They recovered immediately.
Okay.
One child had post-measles pneumonia. It was a big patch. Child's age was 10 months. And he immediately responded to amoxiclav. Like within 48 hours, his pneumonia reduced. It was dense patch, but after 48 hours of augmentin, patch resolved. And after 7 days, there was nothing. This was clear. We gave 7 days of augmentin. And
Yeah, come on. Dr. Hemant, you are the moderator. You have to speak.
No, I want to tell you. No, I'm just telling you history.
Post-measles pneumonia, they respond well to amoxiclav.
Yeah, Dr. Hemant, please go
Yeah,
ahead.
I have benzyl penicillin sometimes. It works in 4 hours. Number one. Number two, I'm telling you history. One island in Atlantic never had measles. And the Europeans went there and they carried measles. Somebody had measles. So they carried 83% population died. So the mortality is proportional to the age. It grows with the age. Thank you.
Thank you. Anyone else for any other comments? Dr. Murthy, we invite you to present a case next time.
Let me see what I have. Yeah, okay.
Yeah, sure.
I'll let you know.
Sure.
Yeah, sure. Thanks.
Please do. Yeah.
Now give your cumulative wisdom. So
sure.
त्यांना 20 मिनिट दे पुढच्या वेळा. My cumulative wisdom. Good idea.
Good idea.
There is a recent news from Somali where measles and the viral lab, that had measles and cholera, they had that mutant strains. They have been captured by the rebels actually.
Oh. And then
it has fallen in a bad people hand.
Bioterrorism.
Oh, you mean to say that was by
from Sudan, in Sudan, where the fight is being going on.
Oh.
So the whole lab that they have they have captured that lab, and the technicians have been made to run away.
Oh God.
थोड़ा सा news है मैम.
Oh. Great.
So I have a good news to share. A self-defense book was made by Jayashree and her team, and it has reached libraries of 488 medical colleges.
Thank you, sir. It's all
Those who want to
because of
read,
our cumulative effect.
those who will read will be benefited.
And the Jayashree and team, and the main leading team is Dr. Hemant Joshi.
Yes.
No, but she made it now over 2 years ago.
Yes. Dr. Hemant Joshi, we salute your efforts to keep writing and keep distributing and keep educating the public.
And keep motivating us all.
So amazing.
Yeah. That motivating made Archana Moti.
No.
No, so
the youngest one, I think.
So I think, Jayashree, we have come to an end.
Yes. Thank you, Dr. Murthy, for your valuable inputs. Thank you, Dr. Naresh Biyani, sir. Thank you, our own Dr. Hemant Joshi, sir. Thank you, Anuradha, for making this happen, getting this MMC credit points. And last, not the least, thank you, our ever enthusiastic President, Dr. Anjali Gokarna, madam. Thank you so much, Dr. Girish Sonekar. Thank you so much for joining all of us. And
Hemant,
there in
Hemant,
every month's discussion. Thank you so much. Thank you so much.
Hemant.
Request to everybody. Please inform everybody that the link is same every time. And that ask all friends to join so that we become a good, because everybody contributes something good. Everybody has learned something new in his own practice. And next time we look forward to 20 minutes of Murti Puja. Done. We will look forward to it. Thank you.
Thank you, everyone.
Dr. Naresh also is there next time. So we have two speakers.
So at least confirm 2 speakers.
Yes, sir. Yeah.
Thank you, Naresh.
Yeah.
Thank you, Giri. Murthy. Yeah.
Thank you, Pallavi.
Thank you, Pallavi Dharmadhikari. She is our IT person. And she has also made the poster, the design and everything. So thank you for that, Pallavi, as well.
And in Jayashree, now, when it is there, all 488 medical college libraries, people would have seen your book. So your program will get a real boost from multiple places.
Thank you, sir. We will definitely approach them.
Done. Bye.
Bye.